Hi. So my journal article was in productive aging, specifically low vision in leisure and social participation in older adults. Multiple topics fall under the category of productive aging, including Alzheimer's and dementia, driving and community mobility, falls prevention, home modifications, and of course, low vision. Our society's aging population will continually need our help adjusting to the rapidly changing world we live in. Think about how the technology has advanced during their lifetime, or how the job force, or housing, the overall economy, and even their quality of life has changed. So in 1960, the life expectancy was 69.77 years old. In 2018, it was up to 78.5. This is important because adults are living longer, which is a great thing, but living longer also comes with the possibility of more health and well-being issues. So the American Occupational Therapy Association has identified productive aging as a key practice area in the 21st century, and it will likely continue to be vital in the field of OT. And low vision just means that these older adults are experiencing age-related vision changes that cannot be corrected with eyeglasses, contact lenses, or surgery. So occupational therapy practitioners can help people with low vision function at the highest possible level. The World Health Organization estimated in 2010 there were 285 million people living with visual impairment. 8 years later, that number was up to 1.3 billion. The majority of these individuals were adults over 50 years of age, and the leading causes were uncorrected refractive errors and cataracts. So let's break down the low vision types. Within that 1.3 billion population, we are going to look at distance vision and then near vision. So remember that normal vision, people can read at 6 meters or 20 feet. So their normal vision is 6'6" or 20/20 for visual acuity. So there are 188.5 million people with mild visual acuity, which means it was worse than 6'12" or 20/40 vision. 217 million had moderate, so their visual acuity was worse than 6'18" or 20/60. And also severe, which was worse than 660 or 20/200. Then 36 million had blindness, which was a visual acuity worse than 360 or 20/400. Then near vision impairment saw a total of 826 million people with a visual impairment. Their visual acuity was worse than N6 or M.08 with existing correction. So AOTA described leisure and social participation as intrinsically motivating activities that support engagement in the community with family and friends. So of course, engagement in leisure and social participation activities helps promote health and well-being in these older adults. Low vision affects the ability to see family, friends, and everyday items in the home and community. They might have trouble seeing their family members, playing a game with their friends, finding the TV remote or pressing certain buttons on it, using their phone, reading street signs, or even a menu in a restaurant. So the systematic review article I used conducted a huge search of relevant articles and added onto some past evidence that was already found. In their search, they included levels 1, 2, and 3 evidence, studies that were published in English between the dates of January 2010 to March 2017. The articles had to address intervention approaches within the scope of occupational therapy specific to leisure and social participation and in older adults with low vision. So here's kind of a workflow of how they found these articles. So during their search process, they searched for over 230 terms relating to leisure and social participation for older adults with low vision. As you can see, they pulled a total of 10,549 articles to begin with. They then were left with 455 articles after wrong populations and non-research articles were removed. Those were then screened and 5 duplicate ones were removed. 450 full-text articles were assessed for eligibility, and then for one reason or another, they ended up removing 447 more. So ultimately, we were left with 3, which I will kind of touch on in the next few slides. So the 3 articles all address social participation, but the researchers were unable to find any that were relevant that addressed leisure in these older adults. All three provided level 3 evidence. Studies included 217 participants with an average age of 77.89. They included both male and female participants, and they all identified as having low vision. So what these three records found was that group therapy, more hours of direct service by practitioners, and fitting these adults with low vision devices led to and had positive effects on social participation. So if we take a closer look, study number 1 recruited 100 participants and enrolled them in a rehabilitation program. The researchers studied hours of direct services provided, indirect services provided, and hours of service related to both services and intervention plans. The PFGP, or the progression of the functional global profile, was used as an outcome measure. Study number 2 interviewed 88 participants 3 months after being in a low vision rehabilitation. This included them being fitted for low vision devices. They were provided vision aids and given suggestions on how to manage daily care activities. The researchers used 4 different outcome methods. Seen here was the Modified German National Eye Institute Visual Functioning Questionnaire, the Hospital Anxiety and Depression Scale, the Mini Mental Status Examination Blind, and indicators of rehabilitation status. And then finally, study number 3 recruited 29 participants to participate in 2-hour weekly meetings over 20 weeks, which consisted of 4 components, which was practical training, education, social interaction, counseling, and training in problem-solving skills, individual and group goal setting, and then home-based exercise program. These adults were also put into a booster session 12 weeks after the program was completed, and they used 2 different outcome measures seen here at the bottom at the baseline, post-intervention, and 6-month follow-up time periods. Some implications to note were, of course, when these older adults were fitted with low vision devices, it improved their confidence and social participation. Optical devices like handheld, monocular, binocular, and autofocus telescopes were implemented. Near low vision aids include handheld and standing magnifiers, and then also non-optical devices like lighting control in rooms or enhanced contrast and reduced glare on screens, whether it be a computer or their smartphones or TVs. That all helps. So although the 3 articles provided great insight into the low vision problems, there definitely needs to be more research conducted to have a better understanding of this issue. Along with more research, occupational therapy education programs should include content on interventions and outcome measures. So in conclusion, we can recognize that being able to participate in social groups and settings help promote confidence and well-being, which makes a lot of sense. We have this very specific group. They're older adults with low vision, and they might just be expected to live at home or be in a nursing home and just kind of sit there. But as occupational therapy practitioners, we should want them to live life to the fullest. So however that needs to be done, by doing research and seeing what really helps these adults is what should be our plan of action. So like these researchers said, there needs to be more work done in this area, but I think the right people could come along and make a huge difference in these adults' lives. And then finally, here's my journal article citation and just a couple other citations from AOTA since I pulled those definitions directly. Thanks for listening.